Good evening to one and all. Today we are here to discuss about what are the different predictors in birth asphyxia. Recently, we visited. Recently we visited Longewala Pass, which is in Jaisalmer. So here I found multiple tanks which Pakistan Army has left there only, and our army has won the battle, and still this we have actually the constant threat of Pakistan and China from to have. So like this, in comparison, basically birth asphyxia is a constant threat for our all pediatricians, where we got succeeded in some way for management by use of some advanced therapies, and there are only few things which can prognosticate such kind of asphyxia related outcome in the child. So in next 15 minutes, I will try to sensitize you regarding what are the different prognostic markers, and I will try to enlighten so that you will have some kind of some messages, take home messages, so that you will be able to prognosticate in case of birth asphyxia. So the different predictors will be discussed here. Now, before going into the depth of the topic, we should know that the birth asphyxia is causing 1.3 to 1.7 per thousand live births. The incidence is very high. And if you see that our own NNPDA data, so extramural pregnancies or extramural deliveries are having 18.1% of HI as compared to intramural deliveries. So the babies who are referred from out, those who are not attended, delivered at peripheral health centers, are having high risk of perinatal asphyxia, where the challenge comes. Now, just to utter the word or write on paper as birth asphyxia is not valid. You should know the proper definition of what is called as birth asphyxia or perinatal asphyxia. The first and foremost important thing is the baby should have Apgar not at 1 minute, but 5 minute or more than 5 minute Apgar, which is less than 5, which is one criteria. Second, pH, which is done within 1 hour of life of the child, is having pH of less than 7, and base excess of the child is more than 12. Then another criteria is the MR findings or MRI findings are suggestive or consistent with birth asphyxia, and birth asphyxia related multisystem involvement is there. If all these 4 criteria only are there, then ACOG permits or AAP permits that to be labeled as a birth asphyxia. So make sensitization of that. It's not simple that baby has not cried, but zala birth asphyxia. It is not like that overseas. Now, so before going into the depth of prognostication of a birth asphyxia, just let me tell you one example. When I went for one resuscitation to delivery, and basically the baby delivered limp. According to NRP protocols, I have to ventilate the child, and baby's heart started, baby's respiration was intermittent, and I was doing ambu back to the child. So at the same time, the obstetrician has asked me, sir, त्याचं काय होईल? त्याचं काय होईल म्हटल्यावर मला ब्रह्मप्रश्न पडला, आता मी उत्तर काय देऊ? उत्तर असं होतं की मी म्हटलं मॅडम बेबी तर सध्या स्टेबल आहे, बेबीला हार्ट नव्हतं, हार्ट सुरू झालंय आणि रेस्पिरेशन बेबी इंटरमिटेंटली घेते, पुढचं मी तुम्हाला अपडेट करतो. तर हे जे आन्सर होतं, दिस वॉज अ व्हेरी प्रिसाइज आन्सर, बट बेसिकली वी ऑल फेस सच काइंड ऑफ प्रॉब्लेम. सो वी हॅव टू प्रोग्नॉस्टिकेट द चाइल्ड फ्रॉम डिलिव्हरी रूम to the end of 7 days or 14 days also, or till the baby is in the NICU or baby comes for follow-up also. So I am going to tell you few of the prognostic markers which are useful to you for prognostication from delivery room. So first and foremost which we are going to do is Apgar scoring. So Apgar scoring is having prognostic value, but not 1 minute Apgar. It is 5 minute Apgar or more than that. So most of the studies has included 10-minute Apgar score less than 3 is having very good prognostic value for poorer neurological outcome. If baby's Apgar is between 0 to 2 at 10 minutes or more than that, baby is more than 80% of the chances are having that the baby is going to have severe kind of cerebral palsy. Now what is the problem of using Apgar as a prognostic marker? Apgar is a retrospective marker. Basically, there is a recall bias. If you find that when you write Apgar, After resuscitation, after stabilization of the child, you consider for writing Apgar, unless and until you have a liberty of having assistant. So in private practice, usually we are one or two to resuscitate the child, transfer the child, and after that to write notes. So recall bias is always there. So this is the disadvantage of that. But advantage is that you have something in hand to prognosticate or tell something to the obstetrician or the parents that this is the condition of the child at this point of point. Second comes the clinical examination of the child. The baby, after this clinical examination, there are two clinical examination findings which can prognosticate the child. One is Sarnat and Sarnat, where this mild, moderate and severe encephalopathy is divided depending on the level of consciousness, suck of the child, grasp of the child, sucking of the child. How we are going to, we are not going to go in detail of that, but we will see how they are going to get prognosticated. So prognostication depending on mild encephalopathy, almost all babies are normal. Most of the babies will not have anything. But if baby is having moderate encephalopathy, then 80% of the babies are going to be normal and abnormal if these symptoms persist more than 96 hours. It's more than 5 days. If it is there, then definitely the baby is going to have some kind of abnormality. If baby is having severe encephalopathy fulfilling criteria, which are mentioned here, your 50% of the babies die. And those who survive have 100% morbidities. The baby is going to have cerebral palsy, some kind of neurocognitive abnormality, some kind of learning disability. Like that you have to tell to the parents and the obstetrician when you are doing clinical examination of the child. Second, very simpler scoring system had come in, that is called as Thompson scoring. The Thompson scoring has scored from 0 to 3, and these are the signs like tone, respiration, suck, grasp, baby's level of consciousness, like that. The highest score is 22 and lowest score is 0. If the score is approaching 0, means baby is having good prognosis. If the score is 0, then baby will be definitely neurologically normal. And if the baby score is approaching 22, if the baby is having 22 score, definitely the baby is going to have some kind of neurological abnormality now or then. So you can prognosticate depending on these clinical parameters. Before going ahead of clinical parameters, you should know that the clinical parameters are affected by many things. What are they? जैसे ही हम बेबी को शिफ्ट कर लेते हैं निक्कू में, बेबी को कन्वर्जन आ गया, हमने एंटी कन्वर्जन दे दिया. मैनेजमेंट इज द प्रायोरिटी, बट वेदर दैट एंटी कन्वर्जन इज गोइंग टू कॉज चेंज दिस काइंड ऑफ पैरामीटर मॉनिटर्ड? यस. Baby's level of consciousness will be disturbed, baby's tone will be altered, even if the level of baby's damage is not that much. So one has to keep in mind that these clinical examination parameters are altered by multiple things. So whenever you are monitoring, try to monitor at a level when the lowest drug levels are there or when the baby's hemodynamic stability is there. Now we'll go ahead. Another thing which is going to prognosticate baby's outcome is hemodynamic instability such as hypotension, PPHN, and baby's need for inotrope gives a very bad prognosis. Now before going into the depth of these parameters like pH, PCO2 level and lactate, which are useful for prognostication, you should know that fall in pH, high PCO2 leads to cerebral vasoconstriction. High lactate level leads to cerebral vasoconstriction and ischemia of the brain, and this leads to ischemic brain injury in addition to hypoxic brain injury which has happened. So definitely if there is fall in pH, there is high low PCO2 and high lactate, definitely prognosis is going to be bad. So this forest plot is showing that cerebral palsy incidence is 2.3 times more in those babies in whom these parameters are normal. Now going into depth of AEG and EEG. So we as a pediatricians, we should know some basics about AEG. AEG is a machine which measures amplitude, which is called as amplitude integrated EEG. And here only 3 electrodes are used. And with these 3 electrodes, even if you are not able to localize where is the site of epileptiform activity, you will be able to find out some abnormality. So even staff nurse or a resident on duty can find out there is abnormality or no. So just focus on these green colored structures. So this map is given here as, see this is an AEG recording over a period of 1 hour. 6 centimeter only strip comes in 1 hour, and in that you will find that all these waveforms are above 5 microvolt and upper end of this also is more than 10 microvolt. So if it is like that, so then it is called as lower margin more than 5 microvolt and upper margin more than 5 microvolt, it is normal. So it is continuous normal voltage, it is normal. It is downstairs is just discontinuous normal voltage, where some of the lower amplitude waves are going less than 5 microvolt and all above amplitude waves are more than 10 microvolt. So it is also normal. But now concentrate what we have to see, when we have to see it as abnormal. So just find out, just see these red colored ones. So downstream is showing that flat wave. We see that these amplitudes are below 5 microvolt. Just simple, your naked eyes can see that this is a flat wave. Prognosis is going to be very bad. Another thing is low voltage, means see that lower margin is just at 5 microvolt and upper margin is not going more than 10 microvolt. So it is a low voltage kind of thing. And burst separation is you are having burst kind of amplitude and then separation is there, but see that it is less than 5 microvolt. So if such kind of three abnormalities are there, you can prognosticate the child for having such kind of bad outcome. So how you are going to prognosticate? See that if the abnormality persists for longer period, see for 72 hours the abnormality persists, then 61% of the babies are going to have abnormality. Sensitivity is going to be low, and specificity wise you can see that 97% of the babies, if this AEEG abnormality persists long as compared to 6 hours of abnormality, 61%. Means if AEEG abnormality persists for long, you are going to have poorer prognosis. Clear? Another thing is time of recovery. Time of recovery is taking long for amplitude integrated EEG to go to that green signal, then it will be a bad prognosis. Then time to establish sleep-wake cycle is also long, then it is abnormal EEG. So just by seeing the this EEG waveforms, AEG, we can prognosticate the child. Then EEG wise, only basic things I am going to tell. You have to see the amplitude. If the amplitude is low voltage, flat traced, burst suppression associated with, is always associated with neurodevelopmental outcome. See, sometimes we have to prognosticate depending on EEG. We call our neurologists, they do EEG and they tell that, sir, there is a flat waveform is there, baby is HI stage 3. You have to talk to the parents to continue or discontinue the baby's treatment. So depending on that, this EEG is going to help us for prognostication or decision making of the child. Neonatal seizures wise, see, neonatal seizures alone are not good. Means it is not like that ki balala jhatke ale म्हणजे ते मतिमंद होणार आहे. It is not like that. When neonatal seizures are associated with other abnormalities such as acidosis, burst suppression pattern or MRI finding abnormal, then only it is having poorer prognosis. So see, if this study shows that total seizure burden in 24 hours, if it is more than 40 minutes, and mean seizure burden, that is in 1 hour if babies have convulsing for 13 minutes, there will be 8 times means odds of having cerebral palsy. So this is the box and whisker plot. Here also it has been shown in similar fashion that the total seizure burden and mean seizure burden, if it is high, then baby is going to have poorer prognosis. Now MRI is very important. Just let me elaborate. If I exceed for 1 minute, give me 1 or 2 minutes. Please, ma'am. So MRI, see, we advise, but we should know when to advise MRI. See, T1 and T2 weighted images should be advised after 7 days only. You should not advise before that. If you want to advise MRI, advise MR spectroscopy in initial 48 hours of birth asphyxia. If diffusion weighted images, if you are advising, then you can advise within 2 to 6 days. So why? Because the sensitivity are going to be more and the lesions which we are going to find out are important. Now see these MRI findings. This is the 2 MRI findings you find while prognosticating or seeing the MRI of a birth asphyxia. This is a watershed infarct and this is basal ganglia involvement. Whenever there is a prolonged hypoxia of near total or not complete hypoxia, we are going to have watershed area hypoxic changes. And watershed hypoxic changes are because of anterior, middle and posterior cerebral artery territories when they are coming at the end. At that area it will be shown as a watershed infarct. And in basal ganglia, when there is a complete obstruction of the supply of blood and oxygen to the basal ganglia, then such kind of asphyxia changes happen. Only 1 minute, 1 or 2 minutes, important thing. So with these MRI findings, see basal ganglia whether involved, watershed area whether involved, and basal ganglia or watershed involved, Barkovic has made a staging, and with that, if only watershed area is involved, we will have cognitive defect. And if basal ganglia are involved, we will have motor as well as cognitive defect. So we will be able to differentiate depending upon the MRI which is findings are there. The same it has been told here. Now, little bit on evoked potential. There are three kind of evoked potential. This is SSEP, that is somatosensory evoked potential. This is visual evoked potential. Then this is simple BERA. So out of these three, only SSEP is having some importance. That is, somatosensory evoked potential is having some sensitivity for prognostication of cerebral palsy, but it is not cost effective. Another is NIRS, that is near infrared spectroscopy, where the brain, this machine measures the regional cerebral oxygenation and it will be poor. This is the last slide. Last. So the crux of my presentation lies here only. The last slide it is. So here at day 1, if you want to prognosticate the child, what investigations you are going to advise is neurosonography, MR spectroscopy and AEEG only. These three investigations are only going to be helpful to you for prognostication, apart from clinical examination. At day 2, MR spectroscopy, sonography doesn't have a role. Why? Because sonography is done for prognostication in birth asphyxia only to see any antenatal permanent changes are there, like cystic leukomalacia is there from intrauterine life, IVH is there, or some migration disorders, if you are the large cystic lesions are there, they only will be able to see. And second, day 2, MRS you can do diffusion weighted images, AEG and EEG. After day 7, none of this is useful. Only T1 or T2 weighted images are useful, because being practicing pediatrician, you will get the babies from different areas, and basically you are going to find useful at what time which investigation is to be done. So clinical, the take-home messages are clinical staging is bedside tool, but it is having low sensitivity if you are using some drugs or baby's condition is disturbed because of the medications. And EEG is not only single thing, but EEG with clinical parameter in combo have a good prognostic value. Diffusion weighted images and MRS are early prognosticators, and evoked potentials and needs are costly measures which not useful. Thank you.
Thank you,
Thank you
Sandeep
very
sir.
much.